disastrous and complicated situation when you face infection of total knee, which is called PJI, Periprosthetic Joint Infection. Actually, all of us who's working in this field, he may face like this situation in his clinic, in his hospital, in his daily practice, especially is working in this field. In different stages, whether it is sinus or the implant outside, or there is pus discharge or continuous drainage. To get away from this complication or from this disaster situation and not get into these knees like you are seeing, which is you cannot differentiate between the femur and the tibia. This is one of the cases where you face infection and you're trying to remove the spacer, whether it's fixed or mobile spacer. Actually, for the old surgeon who's doing total knee replacement, when he faces this complication, try to escape from the problem or has a nightmare and try to put his head away from the theater, that he has no desire to see like this complication. But actually, I am, and you, and who's will work in this field, please open the door and face these problems. Because if we cannot deal it, please refer it to the special center or refers it to the expert, and we can solve the problem easily according to the protocols. Whenever you started, you must have a plan how you deal with these cases. When you have a long trip, always you put a goal to reach safely to the end of the trip. So you check your tire pressure, you check the petrol, and everything you check inside the car, that you will reach safely to the end of the trip. That is what's happening in total knee replacement. You need everything is safe, that you will reach at the end nice surgery without any complication. But we always say prevention better than cure. Why? Because in the prevention or in the one of the complication, you have high morbidity by the infection, or less, you may have even mortality if you have septicemia. So the infection affects the quality of the life, and you may get morbidity and quality. So prevention actually is better than cure. Prevent and take all the measure, not get the complication of infection. 3 factors influence biofilm formation. One of the major factor is the host, the patients. The other factor is the bacteria, what kind of bacteria we are dealing with. And the third one is what's the environment in the theater. So this is 3 factor, main factor influence biofilm formation, and which mean when they mature, the biofilm, this will be infection. In this lecture, I will concentrate on host factors. Please, if you have any question regarding the other factors or even for the diagnosis or treatment, we will discuss later thoroughly about this condition. Regarding the hosts, we have 4 categories that we may take in consideration. We get 80% or 90% prevention of PJI. PJI. So, my lectures will be in combination with the documents and decision taken in the last international consensus meeting, which carried in Philadelphia in USA, which depend on thousands of research, meta-analysis, retrospective, prospective study. The guidelines for prevention of SSI in 1999 says the risk of SSI can be understood or conceptualized according to the following relation. Its equation is depend on the dose of the bacterial contamination and the virulence of this bacteria divided by the resistance of the host of the patient. So according to this, one, if it's increased, the infection will be decreased, or vice versa. This is the equation which have these guidelines at 1999. But imagine in our skin, we contain billions of bacteria, millions, and our mucous membrane contains of billions of colonization of bacteria. So it is impossible for us skin contamination and mucous membrane colonization. So our effort is to minimize the bioburden of the infection at least. How we can do? Start with our planning. There is some factors which is modifiable and some factor is not modifiable. This modifiable risk factor, if we can modify it and deal with it, we end with prevention of PJI. What is about the non-modifiable risk factors? We cannot do anything. Which is not modifiable? That you may have the PJI, but you have nothing to do it. First, the age. The age above 75, more risk for PJI. Gender, male gender, more prone to PJI. Race, black people, more prone to PJI. It is non-modifiable, so we cannot do anything for it. But what's about the modifiable risk factor? This will be, we can categorize it, some of them dealing with screening, some of them dealing with blood tests, some of them dealing with the skin preparation.
Sir, if you excuse me, sir.
Yes.
بس بالنسبه للباوربوينت يعني هسه حاليا هو واقف ولا دا يتحرك؟ is moving؟
هسه دا يتحرك.
لا احنا واقف هسه حاليا.
عليها
استاذ بس اسوي فد شيء. تقدر استاذ هسه تحركه للباوربوينت لانه احنا عندنا حاليا واقف هو. اوكي. لحظه استاذ. صار مين يمك ال
هسه يتحرك عنده؟
لا استاذ لحظه.
هسه
اي هسه تمام.
تمام؟
اي بس I will make the post again. لحظه استاذ. Okay, go ahead.
Okay, everything is clear?
Everything is clear. Okay.
Okay. So we've talked about the modifiable factors and non-modifiable factors, not modifiable regarding the age and race and gender. And regarding the modifiable factor, we can divide it to something related to the screening, something to the blood test, something relating to the skin preparation. One minute.
Okay.
As we say, this is the nasal and this is the guidelines. and this is modifiable. So
تمام.
to start from first point, from the prevention, one of the questions which is highlighted in the ICM, what are the absolute and relative contraindication to elective primary total joint arthroplasty with respect to SSI, superficial skin infection, and periprosthetic joint infection risk? The recommendation was, which is agreed by 90%, that not all the cases must you do TKR. Elective joint arthroplasty is contraindicated in patient with an infectious lesion in ipsilateral extremity until the infection is resolved. Total joint arthroplasty needs to be deferred in patient with anterocontrol condition such as diabetic, malnutrition, chronic kidney disease, as well as other diseases that are known to increase the risk of infection. So to start with, not all the case for the total knee replacement. Some of the cases it's not fit for the surgery, and some of the cases will be deferred. Regarding the screening for Staph aureus and MRSA, they are the commonest cause of the infection. To screen this bacteria, definitely we reduce the risk of the infection. We can take from the nostril 5 probe and culture it. But why I concentrate in Staph and MRSA? Because the causative factors, and also from the personal experience, more than 25% is Staph aureus, the causative organism. And those patients which have PJI, they say it is 18-25% the source of the infection from the nose. So that's why it is very important to screen for the Staph aureus and MRSA for the infection. How we screen it? From the nasal swab, you put the probe 5 times, and you can get the swab to the culture, where you can culture it. So this is the agar, where you could put 5 or to 4 spots for 5 days to culture the nostril. If there is positive, you can deal with it. How you can deal with the nasal infection? By 2 means: 1, ointment, then there is solution, antiseptic ointment. These 2 factors or 2 solutions that we can deal it before 5 days of the surgery. But because of the cost, that you can put it 1 hour before the surgery, antiseptic solution, povidone, iodine with the chlorhexidine. Regarding the second category of the causes is the drugs. We are always talking about the host. First with the nasal swab, then second with the drugs. Which of the drugs that we must deal with it, and important for either continuity or stop these drugs? First of them is anti-rheumatoid drugs, second anticoagulant, third corticosteroids. Those patients who takes these drugs. Regarding anti-rheumatoid, the American College of Rheumatology and the American Association of Hip and Knees states that there is 2 types of anti-rheumatoid drugs. One of them is the traditional one, like you see, methotrexate, sulfasalazine. These drugs not causing increase in PJI. So you can continue by these drugs prior the surgery, unless the patient have very high inflammatory disease. But what about the second one, which is the biological demands? We know as a rheumatoid, we have 2 types, traditional and biological. Biological factors or drugs acting interfere with mechanism, cytokine function, or reduce T cell activity, or inhibits factor that activate B cell. That's why these drugs must be start after 14 days. Why 14 days? Because the wound, it needs to be healed within 14 days. And these drugs interferes with wound healing. So it's better to start after 14 days. And every drug has its own, if you see, this is the literature, and in the literatures mentioned about the drugs which can you continue after healing of the wound. Every drug has its own categories. What's about the anticoagulants? Regarding the anticoagulant, glucocorticoid or cortisone, those patients which taking cortisone, please, if the patient taking less than 15 milligram daily, not stop the daily dose for the patient going to TKI. If it is taking more than 15 milligram, please give him stress dosing at the morning of the surgery. This stress dosing, why? Because it causes hemodynamic instability during the surgery. So 15 milligram is the line between continue or having stress dosing. What's about the third factor, which is anticoagulant? Administration of the anticoagulant has nothing associated directly with the PJI, but it is indirectly, because causing bleeding, and this bleeding causes hematoma, and hematoma is the causing of the PJI. So what to do in this case? This will be the situation when there is overdose anticoagulant. In Health World Organization and CDC, Control Center for Drugs, and ICM, just on ICM Philadelphia, they said avoid potent anticoagulation, not given to the patient. What is the alternative? Is to give the safe is aspirin for the majority, and it is effective as the anticoagulant and has less complication. And if you can to avoid the potent anticoagulant, this is good. The other factor, we end with the nasal swab drugs, and now what analysis and blood parameters detect the diseases that we can modify it and decrease the percentage of PJI and prevent the periprosthetic joint infection. First, blood parameters will help us in detecting anemia. Second, diabetes. Third, malnutrition. This is, we can detect it by blood tests. First, with the anemia. Anemia has no relation directly with the PJI, but anemia means blood transfusion. Blood transfusions means a lot of complication, and one of the factors to cause PJI. It is better to avoid blood transfusion in TKI. So what to do for the anemia is better to treat it by tablet. The minimum acceptable number is 13 for the male and 12 for the female. So start to correct the anemia prior to the surgery by tablets. Only we give IV in this situation when there is intolerance to the tablet, or there is short period before surgery, or the patient has gastrointestinal bleeding. So in these cases, we go to IV injection to treat the anemia. Third, blood analysis is the diabetes. Regarding ICM Philadelphia, Routines, one of the highlighted and agreed by 96%, the routine screening of diabetes and glycemic control has the potential to reduce the incidence of SSI and PJI following total joint arthroplasty, and it is accepted by 97%. What we can do for the diabetes patient, what is our goal or aim when the patient have diabetic and coming to the surgery? First, to reduce HbA1c less than 7, 5, and 8. If you have 10, 11, please tell him, go control it until this number and come to me to do the surgery. Blood glucose must be below that random 200. Many times we take random and it must be less than 200. The other is fructose less than 292. If you can depend on first two factors, that's good. The other factor is the malnutrition. Malnutrition is associated with the PJI and SSI after total joint arthroplasty. Why? Because it caused delay wound healing and wound dehiscence. And if there is sinus, the sinus will be continued. There will be hematoma formation, renal and cardiac complication, and increase 90 days readmission after TKI and complication of PJI. The standards for the nutrient to be in the blood: keep the albumin above 3.5, keep pre-albumin above 18, keep total protein above 6, and total lymphocyte above 1,500, iron above 45, serum transferrin above 200, and vitamin D above 30. And you can do some of the investigation, not all of them. How we correct the malnutrition? These factors must be corrected because your aim to prevent PJI, to prevent the disaster, to prevent periprosthetic joint infection, to prevent two-stage reimplantation. How to correct? By, if there is protein deficiency, by protein supplement or iron supplement or vitamin D, vitamin C, and zinc. The other factor in this lecture I will deal is very important, is the skin preparation. Prior to the surgery, it's better to start for the skin before 48 hours, including most of the body or part of the body is going to the surgery. You can do betadine shower for the limb 2 times at the night before the surgery. You can remove the hair by clippers 1 hour or directly before the surgery. And regarding the intraoperative preparation, because before the skin, regarding the opsites and antiseptic. This is what World Health Organization advised and CDC for the shower bath 1 day before, or shower bath with plain or antimicrobial soaps or antiseptal agent, at least at night before the surgery. The use of the chlorhexidine impregnated cloth the night before the morning of the surgery decreased the rate. It is a trial to get shower or clean by antiseptic or iodine before 1 day of the surgery or at the morning of the surgery. The hair removal by clippers 1 hour or directly to avoid colonization of the bacteria. Regarding the skin preparation, before you put your knife, you can apply opsites and antiseptic. Antiseptic will be included with alcohol and the opsite. And opsite is 2 types. Regarding the alcohol, when you wash the field of the knee, either chlorhexidine with alcohol or iodine with alcohol. But one of the studies done 2019, when by chlorhexidine versus iodine, they observed that wound complication, it's about 2, 3, and 8 with the iodine and alcohol in comparison to the chlorhexidine. And surgical site infection, it's 1 with the iodine with alcohol in comparison to the chlorhexidine with alcohol. And prosthetic joint infection, it was half in comparison to about 2 in when we use chlorhexidine with iodine, with alcohol, sorry. Regarding opsite, you have 2 types of opsite. Opsite is impregnated with iodine, and it's alone without iodine. This eliminates colonization of the bacteria. If it is impregnated by iodine, it prevented 3 hours before the surgery. But if it is alone with iodine, it is about half an hour. So it is impregnated with iodine is more important. And there is one of the studies to prove in about 90% which advise use opsite with iodide. And lastly, I just present this case, my advice that we apply all the measures for the prevention, not to get this complication. This is a man, 55%, has mild osteoarthritis, and they did total knee arthroplasty, and has uncontrolled diabetes that it gets later on loosening and osteolysis. So gradually the instability of the knee joint, and there is more osteolysis and loosening of the implant. It needs the surgery to take the mobile spacer, the all implant removed, and we put mobile spacer, knee, and polythene with the bone cement. Later on, after 3 months, when there's all the infection is settled by the inflammatory markers, we did for him total knee arthroplasty by LCCK with all the augment, and keeping the joint line is perfect. What's the home message? Prevention is better than cure. All risk factors take in consideration prior to surgery. Screening for the staph and nasal. All the drug suspension, which can continue, which not continue. Malnutrition and second contamination must be optimized to reduce SSI and PJI. 70% and even more of SSI and PJI can be cured via prevention. That's why prevention better than cure. I will not get the infection. The last word, and I'll discuss it other lecture, obesity and smoking must be taken in consideration. Obesity, 18 BMI, below 18 BMI and above 14 is risk factor, and current smoking is risk factor. Thank you very much for all. Thank you very much.
Thank you very much. Thank you very much, sir, about this marvelous lecture. And we have, I think we have some questions from the audience. I wish that you can write it in the chat, and I wish you get benefit much from this great lecture and great lessons in it. So I want to ask you, sir, about a few questions regarding the prevention while they are writing their questions in the chat. Thank you very much, Haida. Sir, I want to ask about some of the controversies using the laminar airflow. The ICM suggested that there is no difference between the laminar airflow, whether it is vertical or horizontal. Do you have an answer about this?
Yes, yes. ICM, actually, in ICM, the research or documents, when it's applied by method of research regarding meta-analysis or retrospective or prospective. Mm-hmm. And they agreed and more than 90%. Laminar airflow has not related
Yes.
to any kind of risk factor of PJI. So it is not important and mandatory for the surgeon
Yes, sir.
that has excuse that I have not laminar flow. Be sure from that, have no relation.
Thank you, sir. There's a question in the chat from Dr. Haida. He said that what is the preferred protocol of preoperative antibiotics in low and high risk patients?
Tell me when, let me tell my experience and ICM experience.
Yeah.
For every patient, if you have all the controlling of the risk factor, modifiable risk factor, if it is regarding UTI,
Yes.
regarding the diabetes, and give the appointment for the patient. That's mean the patient is perfect from all the causes. Maybe has diabetic, but the diabetic is 7
Yes.
or like 150. One dose of antibiotic. One dose of antibiotic. I repeat. And this dose given to start from the start, from first minute until last suture by drop. One exception, if the surgery more than 100, give him the other dose. Otherwise, one dose. And for my all patient, I am doing now just one dose antibiotic. No antibiotic, long antibiotic,
Yes.
divided doses. One at the surgery and complete at the theater.
Yes.
No multiple doses.
Mm-hmm.
Multiple doses indicated 3 just in revision cases for infection, not for the instability.
Yes, sir.
And the germ, if it is known, this is another matter. So please, for all the surgeons, don't afraid, don't hesitate that I will give him, because in ICM, there is more recommendation, it will cause resistant bacteria and the infection will be more.
Sure.
One, first generation antibiotic and third generation antibiotic, not using haphazardly. And what's the, why that most of the organism is staph, so please don't use vancomycin for the cases.
Yes.
First generation and third generation.
Yes, sir. Thank you very much.
Okay.
I may add some one point in the ICM. They told about, they discuss about the dose, whether it is long surgery, if it is after 100 minutes or 2 hours. In a revision surgery, you may add another single dose. Yes.
Yes. I said 100 minutes.
Yeah, of course, because they need to minimize the MIC for each drug. Each drug they draw in blood, and for the tissue, which is most in minimal concentration, must be there. So otherwise, there will be a bacterial resistance, as you said, sir. Well, we have another question. I have a question regarding the intra-articular steroid that we give to our patient. Is the time window for IA intra-articular steroid before undergoing total knee arthroplasty? I think is the time you are asking, sir, about the time window between the intra-articular injection of steroid before undergoing totally. Okay.
Look, glucosteroid, as I told you, that it's systemic or tablet, it's can you give him and continue without stopping. But regarding the intra-articular injection of cortisone,
yeah,
2 things. First, it is a risk factor for infection.
Yes.
So it's better if you try glucocorticoid, postpone the patient at least 3 months. At least 3 months to be sure that there is no infection. Secondly, those surgeons dealing with the patient receiving corticosteroid, all the ligaments will be calcified.
There will be ligaments.
And the function of ligament will be, so you must remove this calcification and may affect the instability regarding the medial MCL or LCL. So corticosteroid indicated for this inflammatory arthritis and without aiming to do total knee replacement. Those patients without total or not indication for total knee replacement and inflammatory arthritis. There is pain and there is moderate or mild narrowing of the joint space.
Yeah.
So we can give inflammatory. And highlighted one thing there. What's about hyaluronidase, PRP, everything. In AOS, there is no recommendation for hyaluronidase and PRP. No recommendation for those to use it in. And all of them is study is a trial. It is not proved by literatures.
Yes, sir.
So keep us to the literatures, not to the personal experience.
Okay. Thank you, sir. There is another question regarding the nasal swab. Should we do it, this screening, to every patient or only in the high-risk patients?
Please, please repeat the question.
I'm sorry, the internet connection is unstable. I think you can hear me, sir? All right.
Yes, yes, yes.
Regarding the nasal swab, should we do it for every patient or only high-risk patients?
No, for every patient. It's better. It's better for every patient,
yeah,
because I tell you, 25% with the PJI, the cause is Staph aureus.
Yes.
And 18 to 25%, those patient has the staph in the nose, in the nose. So it's better to screen them. Let us to go to the principle as you can. If you get 50% of this measure in this lecture, I am happy and you are happy and the patient will be happy.
Yes.
So it will be tried.
Yeah.
And even if you're not doing this, you can apply antiseptic to the nurse and you are doing treating even if there is no infection.
Sure.
You know, before 1 hour, apply this antiseptic betadine with alcohol or hexidine, and you will be sure from this, you kill the microorganism.
Yeah, I think, sir, the ICM also suggested that the nasal swab for the patient who has working in the health centers, especially the doctors, nurses who are undergoing total joint replacement, because they have a nosocomial infection risk.
Yes, yes, that actually it is a protocol for the hospitals.
For the hospitals, yes.
It's a protocol for the hospitals, like certificate recommendation that all the hospitals, because the surgery is not the arthroplasty, or even for the other surgeries, they are doing these measures. Yes, correct.
Yeah. Okay. Any more questions from the attendants? Okay, I think we have no questions anymore. Thank you very much. Okay, so we are very proud to be here with Dr. Mahmoud Shahab. Very nice lecture and interesting notes that we can do it, and it's easy to do it. Especially these notes are taken from many doctors, many articles that are assembled in the international consensus meeting. Thank you very much, sir, about your sharing.
Just 1 minute, one yes. point. We are surgeon working in this field, and my personal experience, the infection is the most disastrous complication.
Sure.
If you cannot deal it, please refer it to us or refer it to the center. Can we deal it? Secondly, if you can do even half of the measure, it's better to prevent the infection than you have the infection. My advice for the all working and start or has interest to work, that to get from this lecture some principles to apply for how to prevent PJI infection in knee surgery.
Yeah, thank you very much. Thank you very much. Okay, have a nice day, guys. and we are very proud to be here with you. And thank you. If you have any questions, you can write it down here or in your group, and then you will be answered later. Thank you very much. And this lecture is now recorded, and it will be released to you. Thank you very much, sir, Dr. Mahmoud Shahab. You are very welcome here. And there will be a next lecture. I hope you can share your experience with us.
Thank you very much.
Thank you very much, sir.
Thanks, sir. Bye-bye.